like our new admits have ceased, so we can get started. Thank you everyone for joining our June DRC session with the focus area of triage, infection control, and decontamination. Next slide, please. Okay, so this is just the standard acknowledgement and disclosure or disclaimer, just to remind you that the Pediatric Pandemic Network is supported by the Health Resources and Services Administration, HRSA, of the United States Department of Health and Human Services as part of a cooperative agreement. The content presented today is that of our authors and does not necessarily represent the official views of, nor an endorsement of HRSA, HHS, or the US government. Next slide, please. Okay, there will be some education provided today, and you will be able to get credit for the education. Just let you know that the planning committee and the presenters have no relevant financial relationships to disclose, nor is there any type of financial or in-kind commercial support that was received for this education today. There does tell you about the requirements to claim your continuing education credits on the bottom, and the codes and more information will be given at the end of this presentation. Next slide, please. So today's session will focus on effective response to a measles case within a healthcare or public health setting. We'll review critical control measures, the 3 I's that are listed on the screen, as well as the hierarchy of control. But then we'll really spend most of our time today talking about the key features of measles, as well as a hands-on measles simulation. Next slide, please. Okay, so for our objectives today, first we are going to reaffirm our understanding of the 2 key frameworks that are essential for an outbreak response. So that is the isolate, identify, and inform process, as well as the hierarchy of controls. These are really foundational tools that will help the structure of a safe and effective response in a high-risk situation like a suspected measles case or outbreak. Second, we will then put those frameworks into action through an interactive simulation. And this will really give you a chance to test your current protocols in a realistic scenario. We're hoping that will help you to find any weaknesses or training gaps, and then hopefully everyone will walk away with a clear next steps to help strengthen your response plans. Next slide, please. So I am Doneen West. I am one of your speakers today. Larry Kosiolik from Laurie's Children's Hospital is with us today. Danielle Zier from Seattle Children's Hospital is with us today, and Dawn Bailey. Next slide, please. Okay, I am going to turn this over to Danielle, who will talk about the tabletop simulation and education. Thank you.
Let's advance the slide. And I think this one was Larry's.
Yeah, I'll take the next several. Sorry.
Okay.
Yeah. Thank you. I'm Larry Kosiolik. Thanks for joining and giving us an opportunity to talk. I think the way to start this is to best understand a framework. While we're going to limit this discussion to one disease, the lessons in the next couple of slides really provide more universally to infectious hazards. One framework for highly contagious infectious diseases is something the CDC has referred to as identify, isolate, inform. So the 3 I's. The goal of these strategies are first, that you are prepared and your facility is prepared to be able to identify a patient who may be carrying a communicable disease as early as possible. And that means really at any points of entry. And that can be in the field for first responders. It could be for your colleagues in the medical home, especially prior to referral to an emergency department so that they can identify them and prepare for a safe arrival to your facility, or any of your ports or routes of entry into your healthcare facility, which can most commonly emergency department for things like this, but can also include urgent care or even ambulatory clinics. Once that they are identified, that allows actionable events to take place. First, we want to isolate immediately. Many diseases that we encounter can be transmitted within minutes, and the public health department may actually consider exposure even with transient, unprotected exposure in your healthcare facility. Once you isolate and that patient is protected and your staff are protected, you should then inform the appropriate people inside and outside the organization to take the next several steps that we'll talk about. Next slide, please. Another framework to consider when you are designing your response plan based on your facility is something called the hierarchy of controls. And you may have seen this. This is relevant to all hazards. I provide a screenshot of this triangle that shows 5 types of controls with decreasing effectiveness. And then on the right, with the colored text as an example that might be relevant to the infectious diseases and infection prevention and control world. So obviously, if we can eliminate the hazard altogether, that's the best thing we can do. And a good example of that is vaccines. If we can ensure that we have a threshold of immunity to keep measles, for example, completely out of our communities, that is by far the most effective thing we can do. Next, we can replace the hazard, meaning that patients may still have the hazard, but we can replace that hazard within the healthcare facility. So rather than bringing them into the facility, you may be able to identify them and see them through telehealth if it's medically appropriate. Engineering controls are things that you have inside your building that allows you to best isolate people in the building from the hazard. An example in the infectious disease world would be private rooms, negative pressure rooms, airborne infection isolation rooms. So physical separation combined with ventilation controls to protect people. The next is administrative controls. It's changing the way people work. And so day to day, you may not have very rigorous or intense focus on one specific disease, but if you had a measles outbreak, for example, you might implement more rigorous screening or leverage your EMR to create some prompts for you to be able to identify somebody appropriately. And that's especially important when those that may have first contact are not clinically trained, like patient service representatives, et cetera. And then finally, even though we think of PPE as the hallmark of infection prevention and control, it's actually the least effective because use of PPE implies that patient is face to face with you. And so using various types of personal protective equipment are very, very important, but should not be considered a alternative or a workaround for everything before that. Next slide, please. Let's talk a little bit about measles. So here's the background. And so this just gives a snapshot of how things look historically, going back nearly 100 years, and how things are going now. And so you can see before the introduction of the measles vaccines, we would see hundreds of thousands of cases a year with sporadic outbreaks occurring over the course of many years and with vaccine and waning activity. Once the measles vaccine was implemented, those rates went down. Now, initially, we still had a few outbreaks, but after the 1990s, when the current vaccine schedule was implemented, we essentially eradicated locally acquired measles from the United States up until recently with a decline in vaccine coverage. And so if you look in the past 2 years on the bottom, those are national cases with each vertical bar representing the number of cases that month in that year. You can see there are some sporadic outbreaks between February 2023 and November of 2024. And we're currently in the largest measles outbreak in decades with some improvement and decline in incidence over the last several months. Next slide, please. So with this resurgence of measles in the United States and the rise of vaccine hesitancy and vaccine access, international travel, there's all of these factors that are contributing. It's very important that we all understand what the features of measles are so that we can identify it promptly. Now, I understand not everybody is a clinician, so a lot of these features are not going to be important for you to recognize, but it's going to be important for you to be aware that these features are going to be an important part of your education so that the frontline staff will be able to identify them. Measles is considered very contagious, considered one of the most contagious viruses. Initial estimates were that one person can infect nearly 20 other people. Now it's 10 or more. The incubation period, meaning the amount of time between exposure and disease, is typically 7 to 21 days. So if I was exposed today and susceptible, I would not develop disease for a week. Typically, it would be almost 2 weeks later when I would first develop signs or symptoms of the disease. After about 21 days, if I haven't gotten sick from it, I'm usually in the clear unless I'm re-exposed. The symptoms are very similar to lots of other things, and we usually talk about uh, the 4 C's, which are cough, conjunctivitis, coryza, and Koplik spots. And so what that means is that fever is an important hallmark. The coryza is runny nose or rhinorrhea. There's a cough. So those are very similar to other respiratory viruses. Conjunctivitis with the red eyes, also very, very similar. What is the hallmark of measles is the timing with how the rash presents. It's usually within after 2 to 4 days of the fever starting, usually starts at the head and goes down. And then Koplik spots are fairly unique, which are spots inside the mouth and the buccal mucosa. What's really challenging from an infection prevention and control standpoint is that if I have measles and I enter a room and I'm breathing in that room and I leave, people that walk in that room for more than for up to 2 hours after can still contract that disease even though I've left, and that's because the virus can remain airborne for about 2 hours. Having good ventilation controls can help reduce that. Next slide, please. While many viruses in pediatrics, most people will be just fine. The fact is that that's not always the case, and with measles, it's no exception. There's a fairly significant proportion of children that will have complications. Now, most of them are going to be relatively self-limited in terms of having diarrhea, or otitis media, pneumonia, which will require antibiotics because it's typically a secondary infection. But there are other children who will have much more severe complications. For example, a quarter of children with measles will be hospitalized, and a quarter of those under the age of 5. Between 1 and 3 of every 1,000 children with measles will die of the disease. About 1 in 1,000 can present with encephalitis that oftentimes will result in permanent brain damage. There's a very peculiar and unusual complication of measles called SSPE. That is a very late finding, and that typically happens about 7 to 10 years later, and is a rare, fatal degenerative brain disease. And so it's very hard to sort of relay that to families about a complication that may not happen for a full decade after the virus. There's certainly the pediatric population is a hallmark of the populations at risk. It includes otherwise healthy children under the age of 5, and any child or adult with an immunodeficiency. Adults over the age of 20 and those who are pregnant also have a higher risk of complications. Next slide, please. So I believe now we hand it over to Danielle to kick off the exercise.
Yeah, hi everyone. So what we'd like to transition to now is discussion-based simulation in an informal, low-stress environment. And we want to do this to support a conversation around the use of emergency policies, response capabilities, and identification of crucial partners. Next slide. So we're hoping this can be an open, no-fault environment, and people will be respectful, challenging ideas and not the individuals. And really, we hope you'll try not to fight the scenario, but we do welcome suggestions and recommended actions that can improve everyone's preparation and response. And we hope everyone will be an active participant, ask questions, and be curious. Next slide. So we'll go to the scenario. Next slide. And what we have is a 1-year-old child who arrives at the ED with fever. The baby actually looks well, but the temp is 101 degrees Fahrenheit, heart rate up 140, oxygen saturation 96%. They do have a runny nose and a cough. They are given ibuprofen, the fever resolves, and they're discharged with the diagnosis of viral illness. But then they return 3 days later, and now they have a rash. And the child does continue to have some cough, fever, and red eyes. Next. You can see a picture of this beautiful child. Moving on, next slide. So one of your staff members in triage is concerned about measles, and the parents confirm that the child is unimmunized and recently traveled to an area of the US with an active outbreak. Next slide. So now we'd like to pause for a moment and have people come off camera if you'd like and talk about what immediate actions do you take and what support do you need. And I don't know if we can take down the slide so we can see each other, if that's an easy thing to do. Great. What do people think?
I would first isolate.
Yeah, that's great. Thanks for calling that out. Totally agree. That's one of the first things you want to do. And what are you considering when you're thinking about measles and isolation? Yeah, thanks for the comments in the chat too. Really great. Negative pressure room in the ED, absolutely. And we can talk more about that if you have airborne isolation rooms, airborne infection isolation rooms. And getting IP involved, totally agree. And contact tracing, we definitely want to start thinking about that early because it can take time to put together the lists. Love all these thoughts. Great. Lots of good ideas. Limiting staff to only those who are immunized, making sure people have respirators. Yeah, the PPE, and just thinking about in advance whether you have the appropriate PPE readily available. I think these days we've got respirators readily available. Absolutely, Julie, reporting, looping in public health or your local public health department. Great. Maybe we can go ahead and move on. I think you guys are all over this.
Yeah, I just want to make a comment. I think the limiting staff to only immunize is a really important consideration, and I'm recently discovering that there's more complexity to that from a employee health standpoint. And I don't know how your hospital works, but in ours, employee health is contracted to a partner hospital, is because we're at a children's hospital and don't take care of adults, and so for that reason, our employees are not our patients from an employee health standpoint. And we're not, from our infection control team, are not able to directly communicate with specific employees based on their vaccine status, because that would be private health information. And so we have to partner very closely with our employee health colleagues at our partner hospital to identify those who are non-immune or their immunity is not confirmed, and communicate them to proactively about the steps that they should do to be able to protect themselves without necessarily disclosing any private health information. So something to think about in advance.
Yeah, and we'll have a chance to talk a little bit more about contact tracing here. Why don't we move on to the next slide? Yeah, so you guys were thinking about all of the right things, I would say. Next slide. To dive into a little more depth on the isolation piece of it, you want to immediately mask the patient and move them to an airborne infection isolation room if you have one. If you don't have an AIIR, it's then moving on to a non-AIIR negative airflow room is a great way to go. And then last resort would be just a private room with the door closed. And if your patient is unable to mask or too young to mask, having the parent hold them and covering the child with a blanket is a standard procedure to kind of try to make up for the inability to mask. And all healthcare workers, as you all called out already, should be wearing respirators. And then an important step is to determine whether you need to clear and close the waiting room. Did this patient go through the waiting room? If so, you really want to close any exposed areas for up to 2 hours. The time could be shorter depending on the air exchange rate of your space. And there you really want to seek guidance from your infection prevention and facilities teams, and ideally do this in advance. So you have a whole plan in place about when to close your lobby and for how long you need to do it. And in many cases, these lobbies are so large, it's really hard to have an accurate measure of air exchange rates. So many places will just stick with the 2 hours. That can be super disruptive, so it's helpful to have backup sites for your waiting rooms already called out and a plan for how to implement that. And then if you haven't already, really pulling in infection prevention and control, your local public health department, and right away from the get-go, and having contact information readily available to the staff so they're not left trying to figure out how to pull these groups in. And hopefully there wouldn't be that kind of barrier for your infection prevention group. Okay, moving on to the next slide. I think this is yours, Larry.
Great. And so you notice that we specifically put testing after the isolation, and that is consistent with that identify, isolate, and inform algorithm, and they should always be done in that order. And so we shouldn't wait to test and get a result before we isolate. That patient's isolated, they're protected against other patients and staff that are in that space. And now we can move forward with confirming the diagnosis, as it will have impact on several of the downstream activities. And so most things we test for in hospitals are usually done within your hospital lab or with a commercial reference lab. The Department of Public Health is available for testing for things that have public health importance. And it's important that everybody understand what the recommendations are and the availability and the processes for testing through their local Department of Public Health, as the test offerings and the processes will vary. Next slide, please. So I'm going to give you an example, and this is not a recommendation of what to do necessarily in your jurisdiction, but this is an example of a tool through the Washington State Department of Health that provides guidance on who should be tested. And so this is a tool that provides a questionnaire that's fairly straightforward. Yes or no responses to a variety of questions about the clinical presentation, meaning is it consistent with measles, and the risk factors. Like if you do not have measles in your area and your patient is immunized and they haven't traveled, a patient with a fever and a rash, they're much more likely to have something else than measles. If they are unimmunized, travel, you have local transmission, etc., that the pretest probability is more likely to be measles. And so all of these in concert will help you decide who needs testing. In general, if you're unsure, consulting with your local Department of Health and your infectious diseases team will be able to help you through that decision-making process. You can see, well, let's go on to the next slide. You'll be able to see these in a little bit more detail. And so this just shows with a little bit better quality here with it being enlarged, shows the epidemiologic and clinical criteria that are being collected. I'd point out also that being vaccinated doesn't necessarily mean that they're immune. It does take several weeks for a vaccine to kick in. And so if they were just vaccinated within the last few days, we wouldn't consider them adequately protected. So asking specifically about the dates of measles vaccine helps you sort through that. Also, patients will report, yes, my vaccines are up to date, but they're 12 or 13 months old, and their pediatrician's office maybe doesn't give the measles vaccine until 15 months of age. So really figuring out the specific dates of the MMR vaccine is really important to confirm whether or not they're susceptible. Next slide, please. So this provides some information about the testing offerings and the measures that should be taken before the test is collected if that hasn't been done already. It's important to point out that the specific test recommended and accepted by a public health laboratory will vary by jurisdiction. For example, this Washington State tool requests or will allow at least 3 different tests to be sent. Regardless of the jurisdiction you're in, a nasopharyngeal or throat swab for measles PCR will be the hallmark, and that will be quite sensitive for detection of measles virus. And a fairly rapid result. Some places may use that to also perform a viral culture for additional understanding of the virus that will occur several days later once the virus grows in culture. Others might request urine for the same tests. Some may accept serology testing, such as IgM and IgG. Those usually take a while to come back. They're also, with IgM in particular, a lot of false positives. So in Illinois, for example, they're not requesting serologic tests anymore. They're only accepting a nasopharyngeal or throat swab for the PCR. The nice part about sending it to a public health laboratory is that just the request for the test puts on their radar that there is a patient with suspected measles in their jurisdiction. And so that allows them to get a head start on collecting important epidemiologic information that might be required for community contact tracing, and also allows them to have direct communication with you to ensure that all of those important measures, both inside the hospital and the community, are taken while that test result is pending. If you send it to a commercial lab and bypass a public health department, and then you find out two days later the test was positive, you are well behind in terms of those public health measures, and additional spread could have occurred in that time period. Next slide, please. So the next steps are contact tracing. I think individuals have brought that up, and I like how people brought it up very early, as soon as they suspected it. If you've ever been involved in contact tracing efforts, particularly for something that is spread in an airborne route, where you will likely have lots of contacts over the course of a long period, and particularly if a patient was sitting in the waiting room for several hours while awaiting to get triaged and seen, and the disease wasn't expected, you will have a very large list of patients and families, and it can be a very long, tedious process. And by Illinois state law, this only happens on Friday afternoons. I don't know how it happens in other states, but this always seems to happen on a Friday afternoon for us in terms of doing this contact tracing. Makes it much harder. So the hospital will typically be responsible for the contact tracing within your facilities. And so working with your IT people can help you identify patients that may have been in a similar space through how patients were registered and tracked through the EMR. The infection prevention and control team will work on defining what the infectious window is. And so what's the period of time, hopefully hours and not days, that individuals may have potentially been exposed in that area. On the other hand, the Department of Public Health will do community contact tracing. So when you get those notifications that say, if you were in this airport between these hours and this Starbucks between these hours and this Walmart between those hours, that's the result of the Public Health Department doing really strong work in identifying those patients. Or informing individuals of potential exposures, and the patients will typically work with the Department of Public Health to tell them names or contacts of specific people that they believe could have been exposed, like a classroom of children or a daycare, for example. Many patients may require some form of post-exposure prophylaxis, which would typically be an antibody an antibody medicine or a vaccine, and we'll talk more about that in a bit. Next slide, please. Knowing who is immune is really important, because if you can identify as individuals as immune, they typically will not require post-exposure prophylaxis. So it helps you in determining what you need to do once you do that contact tracing. Your employee health department will help with this as well, but these are generally the criteria that are recommended by the CDC. And so one is being vaccinated with 2 doses, and 2 doses is considered presumptive evidence of immunity for those more likely to develop measles, like healthcare personnel and those who travel. If you're not in that high-risk group, those high-risk groups, just 1 or more doses is considered adequate. If you've had a measles antibody test, that can prove your immunity. If you've actually had measles before, you're considered immune lifelong if you can prove that you've had measles. And then birth before 1957, that's quickly becoming irrelevant for healthcare personnel, as there's very a diminishing number of healthcare personnel that were born before 1957. But 10 years ago, when we had a measles outbreak in Chicago, there are actually quite a few people who were considered presumptively immune based on their birth year. Next slide, please. So once you have developed a definition for who's exposed, infection prevention and control and occupational health will work together. Exposure, remember, as I said before, if I walk into a room with measles and then leave that room, the people that are in that room for the next 2 hours, even though I've left, are still considered exposed. And so if you know a patient was in a certain space for a certain period of time, you would know that those exposed are those that were in that space at that time and up until 2 hours after they've left that space. What we do and what I would recommend everybody doing is having a template for a measles outbreak that allows you to quickly access that template, which will be a line list that allows you to collect all of the important information you need to determine if somebody requires post-exposure prophylaxis. And that's typically age and other markers of immunity, which could be proven immunity from a vaccine or a previous measles test, or if you knew someone had an immunocompromising condition. If you have a data center at your hospital, they may be able to help with this data pool. Like, for example, if you had our Epic team, for example, has a list of immunocompromising conditions, and if you gave them a list of MRNs, can quickly pull all these data. And so having those relationships with your data folks can help avoid the manual data pull. You'll want to notify occupational health as soon as possible. They will confirm staff immunity, and if you will, infection control will help identify the staff who are exposed. Occupational health will identify them at risk and then contact them. If somebody is not immune, they need to be isolated for the next 21 days, because measles, you can transmit it even before you develop the classic symptoms. And so it can be difficult to expose before they become contagious, unless you have a high pretest or high index of suspicion for disease based on exposure. If somebody has received an immune globulin product, either for post-exposure prophylaxis or they are on it as part of their underlying medical condition, we would extend that up to 28 days since some individuals can have a delayed presentation of measles. You'll want to notify all families and give instructions specific to their immune status, which may include post-exposure prophylaxis, isolation that can be particularly troublesome if they're in school or daycare and can be quite distressing to the families, and encourage them to use their PCP for follow-up questions. And then I have some contingency plan for those who don't have a PCP, such as a potentially telehealth consultation at your hospital. It's also important to notify your risk management so that they know you're contacting families and can help you with that communication. At our hospital, we have some pre-developed language that risk management has approved to allow us to do this in a more expedited fashion. Next slide, please. And we'll pass it back on to Danielle.
Yeah, we're going to take another pause and talk about what resources do you have to help you with the administration of PEP. And we can think about both resources that will help you identify what PEP to give when, and then also who are the people, who are the partners that you need to work with to make that happen. So maybe we can take the slide down again and just talk for a few minutes. People have ideas? Well, this will be very exciting to talk about the next few slides then.
Yeah, this is Irene Navis. I was thinking that it would be very important for folks to make sure that their emergency management team, whoever that is, maybe it's one coordinator or a group, also be informed, because they can also be a conduit to other emergency management offices at the local level or at the state level as necessary. That's a really important partnership. Plus, they are likely the conduit to healthcare coalitions to find out if this is an isolated incident or if there are other hospitals also reporting measles cases. So in addition to the public health link, there's also the emergency management link that can be quite helpful in messaging, coordination, and getting resources also into the hospital. Thank you.
Great, thanks, Irene.
Yeah, I think it's helpful to have good relationships with clinical operations teams that are responsible for the stuff, and when you're thinking about alternative care spaces for some of these measures as well. We'll talk through those, but until we had until COVID, the amount of interaction we had with the clinical care teams was pretty limited, because we never really had a need for mass vaccination or mass PEP administration, and so having that those relationships built already, I think, can help respond in a crisis.
Yeah, I totally agree with all that has been said, and knowing where to go to figure out the details of PEP can be super helpful. So let's go ahead and pull up the slides and we can talk through that. Yeah, Chelsea, that's great. So next slide. And next slide. So my go-to resource, and I think many in ID, is the Red Book. And they have a couple of incredibly informative tables. The first one we're showing here is PEP for the non-immunocompromised patient population. And you can see the table is arranged by age, along with that left-hand column, and then the measles immune status, and then the PEP depends on how long it is after the initial exposure. So if you're earlier within that 3 days, if the patient qualifies, they can get an MMR, which is a great, easy way and effective way for long-term protection to give PEP. But if the period of time they're in is in that 4 to 6 day period, then you need to think about IgIM and whether they really qualify for that. Are they a high risk in-home exposure, and a smaller person where that is feasible? And if not feasible, then you're looking at a prolonged period of home quarantine, and really home quarantine appears a lot on this table. The other point I want to make is both of these tables that I'm going to show you have a ton of footnotes, and those footnotes are really, really helpful. They're packed with information. Next slide. Here's the table for pregnant or immunocompromised hosts, so it's arranged in sort of a similar way. And again, lots of important footnotes. And here is where you're bringing in IGIV and all of the issues that go along with that. Next slide. So when thinking about planning for your PEP, you want to be well aware of the timeline, which we pointed out already. For the MMR, that really has to happen within 72 hours of exposure. And it can't, you can't give MMR to a severely immunocompromised host. So then you have your IVIG as another option, and that's going to be for those patients up to 6 days post-exposure and specific groups only, as we were just talking about through those tables. You want to work with your pharmacy and supply chain to validate that you have all the supplies you need, and then work with your operations people to plan for the staffing and the space needed to administer the PEP, with an eye to maintaining your ED capacity. So one way to do this is, thinking about what are those other spaces where you can give IgIM. Urgent care might be an option, and hopefully using clinics for your vaccine. But then also keeping in mind who may need to be isolated. So if you have patients who are becoming symptomatic and they're, a little bit farther out in their isolation period, like getting to day 5 or day 6, you definitely want to be isolating those individuals. So thinking about where you can do that and, considering your post-exposure prophylaxis. And then to gain efficiency around the actual administration of the PEP, you want to think about nurse-initiated standing orders and getting those set up ahead of time, because as everybody knows, well, at least in my institution, it can take weeks to get those established. So we're really happy we have them now for the vaccination and IgIM and IVIG. Next slide. And then I want to just mention here the children and youth with special healthcare needs. We're here with measles, we're specifically thinking about the immunocompromised host, where the presentation may be atypical, both because of the underlying disease and because they receive IVIG. So you may want to consider lowering your threshold for testing in those patients if they've had a significant exposure. We recently had that come up where we had about 50 severely immunocompromised patients exposed, and we worked with public health so that they would accept testing at a lower threshold, not waiting for the typical rash to happen, for instance. And then Skip, I was wondering if you had any thoughts about the mental health implications.
Yes, I always have a couple thoughts. So I think, and I've learned more about that actually hearing the details of what would be occurring, because I think there's some secondary mental health impacts. And I think to start, certainly for particularly the parents of kids with special health care needs and immunocompromised, that's going to be really a target population. And I think generally the mental health breaks down to, the not infected. And it's my understanding that a particular high risk group in that population are parents of infants basically 0 to 12 months before before they're eligible for the first MMR. So essentially, they lack the protective benefits of the MMR until they're around a year old. I guess there's an exception, and I just looked at the CDC website today, so it has not changed as of today, that if the kid is 6 months, between 6 and 12 months, and they're in a high-risk community outbreak or contagion event, then they can get the first MMR. There was a survey that was done in April of parents, nationally representative sample, and basically showed around 48% of parents were worried or very worried about measles in particular. So there's already a context. And then you think about the special healthcare needs on top of that. I don't think that's really been looked at. That'd be an interesting study. So that's one population. The second are kids that are actually infected. And today I learned that 25%, if I heard Larry correct, up to 25% could need hospitalization or be pretty ill. So in that case, the mental health protocols for any kid that, you know, has an ICU level or a significant illness and hospitalization. We have a model. Many of our PPN sites are in our Triage to Step Care Learning Collaborative. Um, we have a children's disaster mental health CONOPS, which includes infectious disease situations. I just put the link to that. That's already vetted by HHS. That's on an ASPR website. But basically, you know, then what are the mental health risk rate for kids that are admitted onto an ICU is around 20 to 30% get PTS or PTSD. So that's a pretty significant mental health complication rate. And that's going to be impacted by the severity of the illness, the length of their stay, what level of medical intervention, medical procedure, secondary stress are they getting exposed to, what's been going on with that kid historically. And that's where some of what our triage tool is designed to capture as well. So in that case, you know, we would want to get to that 20 to 30% right away with evidence-based practice. So it's beyond PFA. That's not a PFA population at that point. They're probably going to need something more. Not all of them, but some of them will. And then I think the last mental health consideration is the impact on staff, especially with staff that may be not vaccinated or their vaccination status is not clear, or if they're pregnant and, you know, those are kind of the totality of the mental health issues as I see them. Happy to take any questions.
Thanks so much, Chip. We'll keep moving, I think, and maybe we'll have time for questions at the end.
Absolutely. Thanks.
Next slide, I think. Now we'll hand it over to Larry.
Great. So now you've done everything you're supposed to do. You've seen the patient, you've isolated them, you've identified them. You've identified them, you've isolated them, and you've informed the key stakeholders. Now you're in the midst of a measles outbreak and you need to communicate. And this, I think, where things get really, really challenging. So I want you to think about a few things here and help us think through this and provide some information either about how you think you would do this or based on your previous experience. But how do you get reliable information about measles out to your community? What information and training does your staff need? And who are your partners in ensuring that the communication that comes out is accurate and effective? And next slide, we'll have these still there. Any thoughts? I know there's a few people in the chat that have, you know, gone through this and they've created some processes.
Hey, it's Julie Cobb from the Jefferson County Department of Health in Birmingham, Alabama. I serve as the Healthcare Coalition Coordinator, and I'm on the team with Children's of Alabama. One thing that we do at JCDH is we always develop a single overriding communication objective, SACO for short, so that all the information that's going out is consistent. And then we work with our existing partners like the Healthcare Coalition, which is the hospitals, EMS, the schools, so that we're all on the same page. I think also it's very important to be out in front of the media and have a face, a reliable, trusted face that is giving that same message to the community.
That's great. Who coordinates? Do you have a specific person at your center that creates, was it SOCO, single overriding communication?
Right, the SACO, it usually comes from our public relations department, but it's written in conjunction with our subject matter experts, like our infectious disease medical director, you know, depending on what the event is.
Yeah, that's great. I think that is really important. I think Jess and Mark make comments in the chat that I think reflect your experience and strategy as well. And that overriding principle is coordination. We've seen a drop in trust of many people in the community, and that mistrust that might be preconceived is confirmed when that communication is not coordinated and can give an impression of that somebody is trying to hide something, or somebody is not well informed. And so that coordination certainly can include at the level of your institution by using your PIO, and whoever's in that role as a public information officer, usually internal communications, marketing, et cetera. Some might have a strategic communications executive at your hospital as well. And then working with your health department or your coalition. If you're in a large city like Chicago, sometimes there's a lot of cooks, and you have a coalition, you have a city health department, you have a state health department, and we've seen some discrepancies in how that information comes in terms of its pace and its level of detail. And that certainly has improved since the pandemic. So thanks for sharing that information. Next slide, please. Next slide. So, when you're communicating, remember that you're communicating to several different groups. And many of those groups are going to require different types of information. It might be different language, different instruction. So certainly when you're communicating with patients and families, just as Julie mentioned, having an external communications person that can ensure that the information that's coming out is appropriate and well coordinated. That'll be on the next slide. Sorry. And then when you're communicating internally, remember that different providers will require different information. And so the clinical staff are those that are going to be in the front lines, and that may include providers, that may include nurses and other frontline staff or ancillary health staff. And it may also include individuals who are not clinical based, but are in the clinical environment, that are not clinically trained, such as interpreters or volunteers that you might have in your clinical setting, or patient service representatives, the front desk people. Email, while it's nice that you can get a single crafted, curated message out, and that can provide situational updates and some very sort of specific bread and butter type of information, some education on how a patient presents, some testing guidance, ability to link workflows and algorithms. It can be effective, but we know that open rates, even among our most informed staff, can sometimes only be 50%. So there's a lot of people that are going to miss those. So you're going to have a way to reinforce the information that's coming out, and create a way where individuals can access information asynchronously. Many hospitals will have an intranet. Like, for example, on our SharePoint, we have a infection prevention and control landing page where we'll post those emails. It allows version control as well. So it allows us to pull old emails off through an evolving outbreak, and make sure that the most recent information is only included up there. And you can also post algorithms. Oftentimes you might have digital signage with QR codes that you can have at elevator bays or hallways, et cetera, cafeterias that can allow staff, break rooms, et cetera, that can allow staff to link to those through their phones. I think staff meetings are really important because it allows you not only to share that information and make sure that they receive it, but also to field questions. And it allows a communication chain from frontline staff to their leader up to the team that's managing the crisis, and allows sort of some bi-directional information to be shared. Community clinicians, I think, are really important as well, because they oftentimes feel ill-prepared and are sometimes intimidated or worried about the implications of having their feet in the fire with you when managing that outbreak. And so utilizing your internal networks is important if you have a clinically integrated network. And for those outside of your immediate access, collaborating with public health or regional health coalition, as was mentioned, is really important. And those communications can include public health alerts, press releases, emails, etc. A lot of education is needed. You can encourage them to leverage their telehealth resources for that well child that's concerned about measles. And I think one of the most important things is to educate on the referral patterns and ensure that they're not sending patients who they're confident don't have measles just for a consultation at the children's hospital, or patients who they suspect have measles and just sending them in without giving us advance notice. And so helping them manage those referral patterns is important. Next slide, please. For patients and families, it's important that everything is tailored appropriately. And reaching families can be very difficult. You may have multicultural and significant variability in socioeconomic status and resources and communication preferences among the various communities that you serve. And so, fortunately, most families, irrespective of socioeconomic status, do have access to digital information. And so utilizing websites and digital alerts, preferably in multiple languages, and being familiar with the languages that are predominant in your community in advance will help you plan for that. Depending on the outbreak, you may set up a nurse advice line or a provider advice line, a call center, to field comments and questions. If you utilize MyChart or some other direct patient portal through your EMR, you can send direct messages. For example, you can have your clinical operations people identify those who are not vaccinated against measles and are due, and can send out direct messaging to those families, encouraging them to get that and instructions for how they can do that. For less targeted communication and those just to the community at large, as was mentioned, collaborating both with your public health department and your external communications experts at your hospital will be important. They oftentimes they should be quite savvy with use of media and social media. I really like the idea of having a specific person or group of people to serve as the source of truth for your organization, working with your media team to assure that they're media trained, really establishing the talking points that you want to hit on, and having a coordinated and well-planned strategic communication strategy. Next slide is Danielle's.
Yeah, and we're just going to pause here and think a little bit about what more can we do? What things have we not yet talked about that could help in your preparation? Great. Thinking about response plans and how that might need to be tailored to the setting, because it's probably going to look different in a clinic than it is in your emergency department. And I agree, drills and exercises are key. Let's go ahead and work through these last few slides. And we'll share some ideas that we had next. Next slide. So, and we've talked a little bit about this, but thinking about the important resources that you have and putting them in a place, ideally, everything relating to measles in one place and making them readily available to your staff in a way that's easy to find is, I think, a pretty foundational step to take. And then importantly, outreach and advocacy for vaccination, working with PCPs to have them identify their unimmunized and underimmunized patients and really prioritize the messaging there and the importance of vaccination for measles. And the nice thing about this vaccine is it's highly effective. So we don't have that barrier around discussing it. And to do whatever we can as healthcare facilities to support vaccine clinics and to help in the create, use, and publication of educational materials for patients and families. We also want to be making sure that our staff is adequately immunized. And on a different note, to think about how we message to our community providers that we really want them calling first if they have a patient that they're referring with concern for measles. And ideally, they're calling our emergency department, let's say, while the patient is still in their facility, so plans can be made and relayed to the patient about how they should approach so that they're not exposing other patients. And then it's a great opportunity to consider televisits to reduce the risk to others. So if there's a patient where there's concern for measles, do you have a way to, do a televisit with that patient as a first step if they're not seriously ill, if they're more mildly ill? So that those kinds of screening questions can be asked from a safe distance. And then finally, thinking about signage and your screener at the triage step, and where do you have that happen? And that can be triggered by what's going on in your community. If you have active measles transmission happening in your community, it's best to have that activity actually happening just outside the hospital. So you're not exposing everybody in the waiting room. Next slide. This is just a little, several examples of signage that can be used to try to get patients to stop. And we actually have a QR code that provides the messaging in different languages and the ability for them to call, and if they self-identify as being at risk for measles, so that we can bring them in safely. Next slide. And this was a measles suspected checklist for providers that I'm not sure who developed this, but it's a nice, helpful tool. These sorts of tools can really help the clinical teams work through what they need to do when they have a patient with concern for measles. Next slide. And here I think we just have a number of different, in the slides following this slide, a number of different resources for everybody. You can see here the AAP Red Book, the CDC, we have some Washington State Department of Health resources and PPN resources. And then the next slide, additional resources for healthcare workers, and another slide with additional resources. So lots of resources for everyone. And I think at this point, I'll hand it back to Donine. Is that right? Or Johnny,
No,
actually.
it's actually going to Irene, yes.
Oh, Irene.
Yeah, very similar, almost the same.
That's okay. We're
make
a
a comment
team.
real
We're
quick?
almost interchangeable.
I-
Thanks, everybody. Just going to finish up with a few slides that Laura would have done if she had been here today. She's off dealing with a death in the family, and so I was asked to do these final slides for you. I hope that you enjoyed the presentations and the tabletop exercise and got a lot out of it. The slides, of course, will be available for you to grab those resources that we just showed. Next slide, please. So just a few things. If you haven't already registered for the PDPAC survey, please register and complete the survey. We have a few responses, but we're looking for more. We want to get as many of the 187 children's hospitals involved in the survey as possible. And I know you've seen presentations and links on the PDPAC before, so I won't repeat that, but we are leaving the survey open for now. There is currently no deadline, but we would like to get it completed as soon as possible, and we will announce a deadline as we get closer to our desired response rate. Also, there's another survey, a DRC tabletop exercise data collection. If you have already been through a tabletop exercise process and would like to complete your survey, we would like to have those sent to that email address there for the DNC. And we would like to have it by, it was supposed to be done by mid-May, but we do have a few tabletop exercises coming up. So just get that in as soon as possible as you go through your process. I know several folks around this table have already been through their tabletop exercise. Looks like we have some things popping up in the chat, so we'll address those in a minute and make sure the questions are answered. We also have some tabletop exercises coming up. Pediatric surge capacity has an exercise coming up June 5th. Evacuation is scheduled for June 12th. And patient tracking and family reunification is a updated date for June 26th. So please email that address shown there below to sign up or receive additional information. Next slide. So the next session coming up for this focus group, TICD, is July 1st, 1 p.m. to 2:15 p.m. Central Time. We will be focusing again on decontamination. Those who have attended previous sessions know that we had a huge response when it came to folks wanting more information on decontamination. So we have a very special speaker scheduled and some additional information that's going to be provided related to pediatric considerations for decontamination. And then following that in August is another collaborative session that will include all of the focus groups, again, from 1 p.m. to 2:30 p.m. Central Time. And there is the QR code for registration for that session. The July 1st session is the same login information as you received for today, but you can go to the website for TICD and get all the information on future sessions and register for whatever you want from there. This is also a reminder that we are continually adding to the website for TICD. And so all the resources that we discuss in these sessions and other resources as we come across them, speaker, the presentations, recordings, all of that, please regularly visit the website because we are always adding to that. Next slide, please. Just discussion on a legal webinar that's coming up. Please sign up for this as well. You see the QR code there, and this is covering pediatric crisis standards of care, revealing the complexities of pediatric crisis standards of care. It is focused mostly on legal issues, but we have a number of experts and folks who are going to talk about gaps in crisis standards of care, ethical considerations, legal and policy, and then have some time for Q&A for folks who are interested in participating in that on June 11th. So please join us if you're able. Next slide, please. And we have a reminder here on continuing education. Physicians, nurses, and social workers are eligible. There's the information, the link, how to create an account, how to claim credit. And if you have any issues, please email there at the bottom so we can assist you. But you should be able to get right in and claim your continuing education. One prerequisite is that you fill out the survey for this, the evaluation for this session. Next slide, please. And speaking of session evaluation, there's the QR code. Please use that code to fill out the survey and let us know how we did today. Every time that you give us feedback, we are able to use that to improve for future sessions. So it's really important that we get your honest feedback, and anything else that you want to tell us in addition to the session evaluation, please put in the chat. And I think that might be the last slide. Next slide, please. That's it. Deneen, would you mind putting in the link for folks who aren't able to grab it We just had a request through the chat. Thanks. Or Eleni, I'm not sure if you're able to put it in there. Thank you so much. Any last words, Larry or Danielle or Doneen?
Not for me. I just hope everyone has a great day.
Yeah,
Great. Thank you
great
so much.
comments and questions, and appreciate the opportunity to talk about it. Thank you.
Thanks, Larry. Anything, Doneen, that I missed telling
Nope.
folks?
Great job. Thank you,
Great.
guys.
Thanks. And the best news is we got done early. So you have 4 minutes back to your life. Have a wonderful, wonderful day. Thank you, everyone. Take
Thank
care.
you.
Thank you, everyone.